Hi, good afternoon.
Hi, good afternoon.
It's 12:03, so I think we can begin, and of course, welcome everyone who joins at their convenience. Today, we changed the agenda. Dr. Strosberg and I are here for a Q&A, and we'll be here till around 12:30. So we will start by welcoming any questions, and if you need some time, I also have some questions that can start our discussion. You can raise your hand and we'll know to give you the floor, or you can place your questions in the chat. So I'll begin with a question. I have two concepts actually that are shaping some of my clinic discussions and helping us with some treatment changes from years past. So Dr. Strosberg, there are two things that come to mind. One, in treating well-differentiated neuroendocrine tumors and NETTER2, which is something we've touched upon in the past, and we have some educational webinars about it. But can you share your thoughts about that and how you're introducing that into your clinic?
Sure. So I think, as many people know, peptide receptor radionuclide therapy, PRRT, using Lutathera has been approved since 2018 for treating patients with progressive, well-differentiated neuroendocrine tumors, meaning neuroendocrine tumors that are growing, typically after at least one prior line of treatment. Often that prior line of treatment is a somatostatin analog like sandostatin or somatuline, but it could be other treatments as well. NETTER2 looked at first-line Lutathera compared to high-dose sandostatin patients with relatively aggressive neuroendocrine tumors, meaning a Ki-67 above 10%. And not surprisingly, it showed that Lutathera resulted in a much longer time to tumor growth compared to sandostatin. And that was a primary endpoint of the trial. So it gives evidence that we can use Lutathera as a first-line treatment or as a very early treatment in patients with relatively aggressive or fast-growing tumors. But at the same time, Lutathera has a lot more risks and side effects than sandostatin. And so the question is it enough that it slows down time to tumor growth or results in a lot more tumor shrinkage to justify the risks? And the risks include a 2 to 3% chance of developing leukemia or myelodysplastic syndrome, and then there are other risks as well. So I still think it's kind of an individualized decision, and based on other factors like how many tumors there are, how aggressive does it look, how many symptoms do patients have, things like that.
Mm-hmm. And so just to wrap up, I think it's still very much a systemic therapy with best used where there's a burden of disease to address, not a small amount. But it does bring in Lutathera in a higher grade tumor as long as those receptors on a PET dotatate are uniformly expressed, and then brings it in also as a first-line treatment, potentially in that setting. And then I wanted to point out also that between the data for the initial approval and then this newer study, it encompassed more primary sites, right? So NETTER1 was really focused on small bowel, but here we have documented experience with pancreas included and lung primaries as well. So that's a little difference there too. We have some questions. And the first one is, what is the role of enucleation for pancreas NETs as opposed to standard of care surgeries? Any difference if tumors in the head or tail? And then for tumors less than 1 centimeter, I think that's what it says there, any particular treatment recommendation? So enucleation, in particular to pancreas NETs, my approach in general is to first see how was it found. Was it found in a functional state causing symptoms, in which case observation is not my approach? but I would look at removing it with surgery. Or was it incidentally found, like coming in with kidney stones and then incidentally finding a mass on the pancreas on that CT? So if it's non-functional, meaning it's quiet, then I look at what is its pathology, is it indolent, low grade, and what its size is. And so if it's not approaching 2 centimeters, we do have data that shows that observation in a non-functional low grade tumor is very appropriate, and exposure to a higher risk surgery does not have to be pursued at that time. But that does not mean that we do not continue active observation and intervene if there's a change in that size. And of course, keeping in mind that the surgery is completely different if it's in the head or tail. So we're looking at a potentially more extensive surgery if it's in the head. Dr. Strosberg, what are your thoughts about enucleation? We do use it quite a bit.
So enucleation is basically a non-oncologic surgery, meaning a non, with cancer surgery, you try to get good margins and you try to remove lymph nodes where cancer tends to spread first. With enucleation, you're basically trying to kind of sort of scoop out the tumor from the pancreas. And so the result is that you're usually not getting lymph nodes and you're not getting good margins. It's only appropriate for patients with small tumors that are kind of sticking out of the pancreas, not involving the center of the pancreas or the main pancreatic duct. I think it could be an option for a very select number of patients. The perception is that enucleation would be a lot less risky or less toxic than a major pancreatic surgery because you're not, removing a large part of the pancreas and you're not having to reattach portions of the pancreas. But in practice, a lot of patients experience leaks after enucleation. So the pancreatic enzymes basically, because you're kind of slicing into the pancreas to remove the tumor rather than cutting right through it, you can get a lot of leakage and and infections too. So it's not as simple as it would seem in many cases. And so in practice, we do enucleations very rarely.
I agree with that. What is, we had a webinar before about genetic predisposition, and we talked about MEN, where our patients might be more at risk for multiple tumors in the pancreas. And that's where this observation for smaller tumors is more appropriate, because we want to be cautious about how many surgeries we're doing to the pancreas or removing entire pancreas as well. Would you agree with that?
Yeah, with multiple endocrine neoplasia, as you said, there tend to be multiple tumors, and they're often stay small, don't grow, and unless you want to remove the whole pancreas, there's going to be more. So yes, observation is appropriate in many cases for multiple endocrine neoplasia, and also, as you pointed out, even for patients with just sporadic, incidental, small pancreatic neuroendocrine tumors. We know that if we were to take, a large group of healthy elderly people, let's say 70 plus, and do really good imaging of their pancreas, we would find tiny pancreatic neuroendocrine tumors in a lot of them. Clearly, the vast majority of these are not going to become malignant and spread to other organs. And so, this is a problem of overdiagnosis when we find these tumors incidentally. We find a lot of tumors that would never cause problems during people's lifetime. And so the goal is not to hurt them with a surgery that, even though, these days is relatively safe, there still is a mortality associated with it. People can die after pancreatic surgery. So we have to be careful.
Right. We do have a second question about a hot topic that comes across histotripsy. And we did have a prior webinar where our colleague, Dr. Al-Haddad, really spent time describing it and explaining it. Where I see histotripsy come about in neuroendocrine oncology care is to address metastatic liver tumors. And so I view it currently in the context of liver-directed therapy. But it's different from embolization in that it's using high energy to basically liquefy or cavitate that tumor. At present, there's data for liver cancers. We do not offer it at present at Moffitt, and it hasn't outcompeted the other liver-directed therapies, so there's no direct comparison making it more superior. So I think there's room for it as a tool in treatment, but it is not proven to be superior to the tool set that we have presently in terms of embolizations. Those are my current thoughts about it. You, Dr. Strosberg, you can share yours as well.
Yeah, so, devices can be approved with very little data as opposed to medications. And when I looked at this a few months ago, I could barely find anything published about histotripsy. And the presentations that were presented in abstract form described outcomes just days after the procedure. So as far as I can tell, and also by talking to interventional radiologists who do this, there's almost no data on how well this works and how safe it is in the long term. And nor do we have a lot of information on the subtleties. For example, there are parts of the liver where you can't even do this properly because of the interface between the lungs and the liver, for example, or it's probably parts of the liver where you can't do it safely because it's close to major blood vessels and bile ducts. So I think we're going to be learning a lot about histotripsy as it's done in real life in clinic. That's often how it is with devices. You have a lot less information from clinical trials, and people accumulate experience with treatment. And so I hope we're able to offer it at Moffitt sometime in the near future. But people doing this need to be aware that it's not a panacea, and it's we still have very, very little information on how well it works and how safe it is.
Right. Sometimes having something new requires a bit more time to know how to best apply it. So it's definitely has room for growth there.
What it's most similar to is microwave ablation. So currently we treat some patients with microwave ablation, meaning we insert a probe through the skin into the tumor and burn it, I believe using the same energy that histotripsy uses, except histotripsy is non-invasive in the sense that you're not inserting something into the tumor, you're doing it through the skin.
Right. And I would encourage you to go to our library on the website for FLaNET, and there's a more thorough discussion about histotripsy as well. While we take some time to receive more questions, another concept that we've actually talked about even with colleagues at other institutions is addressing the other side of the spectrum of disease in neuroendocrine oncology, specifically poorly differentiated neuroendocrine carcinoma, wherein we're not looking at PRRT, but we're looking at chemotherapies, possibly immune therapy as well. And in the past, we had our colleague join us from University of Miami to discuss DLL3 clinical trials that are using a form of specific immune therapy. And more recently, within that spectrum is small cell lung cancer. And there's a new medication that just became approved, tarlatamab, that looks like a superior second line option after chemotherapy when this particular cancer cell type progresses. And we hope that it might be applicable for our patients with neuroendocrine carcinoma. So we're getting questions about that in clinic. My preference is to continue to pursue our clinical trials, specifically looking at this because it's a controlled environment where we're really answering the question, does it work for our patients who have neuroendocrine carcinoma that originates outside of the lungs? But we've spoken about, now that we have this available, how does that impact when we look at, next treatment line after chemotherapy? What are your thoughts?
Well, tarlatamab was just approved for small cell lung cancer. It's a medication that's administered intravenously. It requires hospital admission for the first several cycles. Whether this is something we'll be able to get approved for patients who don't have small cell lung cancer is something I don't know yet. It was just approved last week. Clearly, it's going to be a lot better. Both for, I think, for the patient as well as to improve our understanding, if we can enroll patients in a clinical trial that's sponsored by Boehringer Ingelheim, BI, that's looking at a very similar drug that it's a bispecific antibody targeting DLL3. That study is currently on a break while they're analyzing the data, but hopefully we'll be reopening in the near future, and when it does, we're hoping to have it available at Moffitt.
And I think having access via the clinical trial kind of bypasses a wait time, because if we are applying for off-label use in a high-risk malignancy, waiting for something to be approved might allow this to progress or cause symptoms that we could have avoided with a more prompt treatment. So I'm very careful in taking that time if it's going to take a few months to get it approved off-label. However, I am equally excited about seeing this, at least for small cell lung cancer, because it brings up my hope for other neuroendocrine carcinomas. And I'm excited to have the trial open up for us as well. But it is a very needed, positive step forward in treating this particular diagnosis. So I wanted to take time to share with our community.
Yeah, I mean, in small cell lung cancer, we're really seeing, I mean, we're really seeing long-term survivors with this drug, which we almost never saw. And again, we're talking about poorly differentiated neuroendocrine cancers, not well-differentiated neuroendocrine tumors that I think most people in the audience have. But for poorly differentiated neuroendocrine cancers, the prognosis has been quite poor. And the data from small cell lung cancer suggested about 30 to 40% of patients seem to really benefit in the long term from this, which is, not something we've seen before in this disease.
Right. I think one of the challenges is you can have a response because it's quite receptive. However, maintaining that response and control long term is the challenge. And we're actually looking to see how can we be more informed to predict either response or resistance to treatment thereafter. So we're not only focused on therapies, but understanding the actual tumor genetics. And I think that'll help with future therapeutics as well. Ms. Banker, you said you wanted us to repeat what we said about elderly and pancreas nets. And I think it was potentially something that Dr. Strosberg said, wherein sometimes these smaller tumors are incidentally found where they would not have impacted the well-being of the patient, and we take into consideration the biology and age. I mean, do we anticipate this tumor to grow to impact the overall timeline of our patients? And that sometimes speaks to their age, being diagnosed at age 30 or 40 versus 70 or 80. We have a new question. Can capecitabine temozolomide be equally effective on metastases, which are located in lung, bone, lymph nodes, pancreas, and liver? So I view capecitabine temozolomide as a systemic therapy, and I often use it in the metastatic setting where metastases can have traveled from the pancreas to the liver or lymph nodes. And my intent is to treat all of these sites with this systemic combination. However, I will note that sometimes when we do our restaging scans, there can be subtle different genetics and different clones of a cancer. And so we might have a dominant area that does break through that control. For example, a particular liver lesion or mass that, despite everything else being stable, will grow. And that might speak to this, cancer is not only one clone, and that, that we have selected this one area that has broken through, and we may add another treatment to address that. So Dr. Strosberg, I don't, not offer CAPTEM if there are bone metastases versus liver versus lymph nodes. I view it as a systemic therapy.
Yeah, we have to distinguish between primary tumor and metastatic tumors. When we talk about pancreas, that's usually where it's but there's no reason to suspect that some metastases respond better than others. In most cases, the liver is by far the most common place where these tumors spread to. But we have no information to say that it works better when it spreads to one organ or another. The primary tumor in the pancreas sometimes responds a little bit less than the metastases, though, in my experience.
And in our practice, we more often use this combination for pancreas and sometimes a heavy burden of disease with bronchial or lung mets as well. The question, though, that has been a topic of discussion in the past is when we are trying to make a decision between PRT and CAPTEM, for example, how do we approach our second-line treatment after using a somatostatin analog? And we do have clinical trials seeking to answer that question so that we can be more informed and more precise about where to go after the first treatment. And that is forthcoming for better guidance, and I think will be contributing to our guidelines.
Yes, I agree. It's very hard to know right now how to best sequence treatments, especially in pancreatic nets, where we have different options, but not much information on how to best sequence them. Ultimately, the goal is for people to live as long as possible with the best quality of life as possible. And these are very, very hard questions to answer because we don't know what implications are treatments now, even if we can measure how long until the tumors grow. The question is really what impact the treatments have on overall survival and how to best sequence them to do that, to maximize that. And very, very hard questions to answer, even with clinical trials.
And it takes a long time to answer.
It takes a long time, and you need a lot of patience. And this is a relatively rare cancer.
I think we've answered the questions so far that are in our chat.
All right. Well, it's almost 12:30, so.
Well, let's take another couple of minutes. We have our national society meeting forthcoming in November, and we're getting ready to be presenting there some of our experience, and we're going to time another webinar thereafter so we can share what new guidelines are coming out from us with our colleagues and shared experience in terms of research as well. This is a time where we get prepared for this meeting, so there's a lot of effort going into that, and we're really excited to be there to advocate for our community.
Yeah, thank you. And I also want to mention, we're going to work over the next couple of months to improve the website. I know that there have been some issues with it, but hopefully by the end of the summer, we'll have a better website going on.
Yes. Yes, we did discuss histotripsy, so we will save this webinar and you can review our thoughts about it. And there is a prior webinar where it was more of a highlighted topic, and so both will be very good resources for you. That was another question that came up on our chat. Okay, let's take these last 2 minutes to answer this PRT question. Can alpha PRT have less collateral damage than beta PRT? So go ahead.
We're doing trials now with alpha PRT, both lead and actinium. The lead trial actually has just completed accrual. We'll be presenting the data actually next week at a national meeting. At least the preliminary data. It's not the final data. I mean, my gestalt is that it works better. That's the the response rates are generally higher. But as far as collateral damage, by which I assume we mean side effects. I think the side effect profile will be a little bit different from beta. So far, we're seeing, for example, less bone marrow toxicity, but I think we'll see other side effects. I think it's a little bit early to know precisely what those side effects are and what the percentage of patients experiencing them are. But there's definitely side effects that we're seeing with alpha emitters that we don't generally see with beta emitters. So I'm very hopeful that it's going to be more effective. As far as tolerability, it's going to be different.
I think maybe the comment is also speaking to it is higher energy but shorter path, and so are we being more precise? I do agree that I think I foresee or would not be surprised if it is potentially a higher response rate, but it is not without its own side effects. And I agree, we saw some that we have not seen with beta emitters. So while PRRT is growing and with new drugs available, I think it still is, side effects are important to consider. Whether alpha will replace beta, I think, is not anytime soon. I think this expands the medications. There are more data, at least with the clinical trials we have, about using alpha in the retreatment, meaning we have used Lutathera and looking at retreatment with PRRT. And so perhaps that will be the first step where it kind of shines. But whether it will or become our primary treatment, I think would take time to look at that.
Yeah, agreed.
All right, 1 minute. I'm really excited to have more of a group and questions coming through. So thoughts on increasing lanreotide from every 28 to 21 days when there is small tumor growth seen. So the question is decreasing the interval of somatostatin analog to address a small creep in progression, a general next step. And I would say in my practice, no. I do sometimes change interval to address clinical symptoms where I'm understanding that the week leading up to the injection of a 28-day interval is more symptomatic, and then I switch to 21 days for symptom control. If it's not a significant interval growth, I usually wait till my next restaging. And if it is significant, then I look at other treatments rather than switching between somatostatin analogs or changing the interval at present, because we do have other options. You can share your practice as well.
Yeah, I agree. We don't have any good quality evidence saying that either increasing the dose or decreasing the interval slows down tumor growth, and that's both for sandostatin, which is octreotide, and somatulene, which is lanreotide. That being said, there may be a little bit of benefit, and in patients who have mild growth that's insufficient to justify switching to something more risky or that has more side effects, we have in some cases done exactly that. So I think it's reasonable, it's safe, but whether it helps or not is really not well known.
And we want to make changes for a clinical impact. So a millimeter of change, does not require a complete change in treatment. We want to, maintain quality of life. We want to maintain symptoms, and somatostatin analog is very well tolerated, but it's not without symptoms. And we want to make changes when there is a true change in behavior as well. So the point being not to overtreat or throw away the first line of treatment for a very small change.
Yeah, and we also know that when Lutathera was compared to doubling the dose of sandostatin, the doubling dose of sandostatin was far inferior to Lutathera. So at best, changing the interval or changing the dose, increasing the dose would have a minor impact.
All right. Oh, I want to thank everyone for joining and coming together. And we look forward to next month's webinar. We will save this for anyone who wants to review some of the questions. And we'll see you next month.
Thank you. Bye-bye.